Okay, yeah, sure. We'll get started. And I was planning to cover the deposition diseases today. So I'm going to be teaching you the blue and the pink deposition diseases. And so let's get started. So, the um, all these diseases is something that if you have seen them once, you will remember them. And, the books often go crazy about them, but they are not many testable entities. And most of them are classic. So try to remember them in the order that I teach you. So the blue deposition diseases essentially indicates, mucin and mucin-like substance, but mostly it's mucin. So the first thing we're going to be talking about is pretibial myxedema. And pretibial myxedema, the biopsies are essentially, pretty straightforward. You basically get most often a punch biopsy. It has to be a punch to show you that the mucin is going deep into the dermis, often infiltrates even into the upper subcutis, but there is very sparse inflammation. So other than the mucin in the slide, there isn't anything much happening. There is no vascular proliferation with it. You may see some evidence of stasis change, so don't mistake that for any kind of a vascular tumor or anything, depending upon where the biopsy has been taken. But other than that, it's a pretty unremarkable biopsy with but just lots of mucin which is visible. Now, uh, if you have a similar slide with a lot of mucin, but you also have accompanying perivascular inflammation, so superficial and mid or deep dermal perivascular lymphocytic infiltrate, perifollicular inflammation with lots of mucin, that's when you think about plaque-like cutaneous mucinosis or reticular erythematous mucinosis. That can look like tumid lupus, but the difference between the two entities in tumid lupus, it's the infiltrate, the lymphocytic infiltrate with the tight cuffing that grabs your attention. And once you determine that there is a lymphocytic infiltrate, you go and you look for mucin. Mucin is not the most prominent feature. It's the opposite in plaque-like or reticular erythematous mucinosis, where you really see the mucin and then you see, okay, there is inflammation, and then you tie the two together. I have to say, however, that's a very rare entity. It's not something that we see very often. It requires strict clinical path correlation. So, most often if that entity is put in your boards, it's a distractor. So, I wouldn't really be looking to go in for the diagnosis unless and until the features are pretty, classic as what I described. But pre-treatment myxedema, really important both slide, tons of mucin, but no inflammation and no other specific change happening in the biopsy. Okay, so now we're going to be talking about some entities which present as lesions. So more of in neoplastic entities as compared to your inflammatory entities with mucin. So the first among them is your if you just get mucin in the slide, focal cutaneous mucinosis. So this often presents as a papule clinically mimicking either a nevus or a basal cell, and what you will see again is just mucin. There is minimal other change in the biopsy. Now, the histology of focal cutaneous mucinosis or a myxoma, which is a benign tumor with mucin deposition, is pretty much similar. The subtle difference can be that myxomas often have some slight degree of vascular proliferation. So it looks more tumoral. So, it will have like some angulated fibroblasts, some degree of vascular proliferation, but essentially the differentiation between mucinosis and a myxoma, if it's a solitary entity, is not that important. They can show you this slide and then they can ask you second order questions that what are the myxomas associated with. So you get myxomas in Carney's syndrome. So right, am I right? Carney's is what you think about, right? The myxomas. I'm pretty right, but just check on it because they may show you a slide and they may ask you a second order question with it. Like, what is this, multiple of these lesions? What is the syndromic association with it? So that's your.
Just a quick question. So
yes.
Okay, Katie confirmed you can get myxomas in Carney complex, but is a myxoma the same thing as focal cutaneous mucinosis?
So it's not the same. They are different entities, but the histology can be very similar. And often we use overlapping, synonymous terms based upon what the clinical presentation was. Focal cutaneous mucinosis most often presents as like the clinical is nevus versus BCC. It's a tiny papule with lots of mucin. And myxoma is also a solitary lesion, but they tend to be bigger. And some subtle differences between the two is like myxomas, they look more like a tumor. So they will have more fibroblastic proliferation, more vessels, but essentially the histology can be very, very similar. So they should not really put mucinosis and myxoma in the same differential because, it's not essentially necessary to differentiate between the two. But they
Okay.
can give you a slide of it and they can ask you a second order question in which they will be referring to a myxoma.
Okay, got it. Thank you.
Okay. So the next entity with mucin deposition, which is, again, a tumoral entity, is your digital mucus cyst or a pseudocyst. So this is not really a true cyst, and it has, again, a classic presentation. You often see it on the acral skin. So you will see the biopsy of the acral skin. The epidermis overlying the pseudocystic lesion is kind of thinned out, and you see this kind of a bubble-like space, which is formed because of mucinous degeneration of the stroma, but there is no true cyst lining. And the adjacent, the stroma, it will show these kind of angulated fibroblasts again with mucin deposition. This is considered to be the superficial variant of a ganglion cyst, and this is how it classically looks like. This is a digital mucus, cyst, or a digital mucus pseudocyst. It is a pseudocyst because it doesn't have the true cyst lining. Okay, this is another biopsy from a digital mucus cyst. This one is showing you the nice mucin without the bubble, but again, you can see the acral skin, and then the overlying epidermis overlying it is often thinned out. And you can see this nice mucin with some fibroblastic proliferation. That's again a digital mucus cyst. The next one is going to be your mucocele. So mucocele, which presents most often on the lower lip, it occurs because of its obstruction of the draining mucin from the salivary gland duct, which causes the mucin to leak out, producing an inflammatory response around it. So first of all, the mucocele, you can see different kinds. So in the most, the obvious one is when you see the mucosal skin. So you recognize it to be the mucosa. There's no granular cell layer. You see the surrounding salivary gland tissue. So you can see, okay. And then you see this big kind of an empty space. And the space actually has mucin in it. So you can see the nice mucin in the space. And it's walled off by this inflammatory granulomatous response. So you see this, again, kind of like a pseudocystic space, which has been, the wall of which is lined by all this inflammatory cells and histiocytes, which are, trying to clear up this mucin. So that's your, one mucocele. When you have all the features, you have the mucin, you have the inflammatory response, and, it's easy to make the diagnosis. In some other entities, it may be a little bit more difficult because you may not see mucin, which is obvious. So this is, again, you see that this is the mucosal epithelium. So you can see the nice mucosal epithelium, the salivary gland tissue. And here you do have the adjacent mucin. So, that's, again, simple and straightforward without the inflammatory response around it. So that's a mucocele. This is the kind one which I'm saying, which may be a little bit more challenging, where you do not see the mucin. But sorry, I don't know why I'm having problem focusing the slide. So you can again see the mucosal epithelium, the salivary gland tissue, and now you see here a big empty space with no mucin. That's because the mucin is inside the histiocyte. So all these inflammatory cells, these are actually muciphages, which have, taken up the mucin inside them. So if you were to do a stain, it would actually highlight the mucin inside these histiocytes, but you actually don't see any mucin within the space. So that, again, is another type of a mucocele. Okay. Now, let's talk about your inflammatory conditions again with mucin. The most common is papulomucinosis. So papulomucinosis or lichen myxomatosis and scleromyxedema are all in the same category. Papulomucinosis and lichen myxomatosis, typically patients present with this kind of a papular, eruption, and it all has to be taken in the right clinical scenario. So papulomucinosis, without any systemic presentation of paraproteinemia, is put in the category of, your papulomucinosis, which can be of varying types. You most often will have to work up these patients to make sure that they have normal thyroid function tests, they do not have, hep C infection. And then you can put them in any one of the category, idiopathic, or, you have your nodular mucinosis, acral persistent papulomucinosis of, infancy. So there are different kinds which, your textbooks highlight really well. The important thing is that the histology of papulomucinosis and lichen myxomatosis and scleromyxedema is all very similar. So what does a papule show? So first of all, it looks like a busy dermis. So the low power view of it is actually the impression of granulomedullary. So as you can notice over here, that this particular lesion, it involves the upper and the mid dermis. So that's where the papule is. and it produces a differential of busy dermis. So you think that maybe it's GA, there is something happening in the dermis. But when you go on high power, you actually see that unlike GA, there is fibroblastic proliferation and fibrosis. So you can see that this particular papule has all these increased nuclei. And the nuclei are because the fibroblasts have, proliferated. So you can see that there is an increase in the number of fibroblasts. So all these spindle nuclei, the fibroblastic nuclei, they have laid down the collagen. So there is fibrosis as well. So you can see the thickened collagen bundles. There is mucin and there is inflammation. So essentially everything is increased. You have fibroblastic proliferation with increased fibrosis, you have inflammation, and you have mucin deposition. Notice another thing about the fibroblastic nuclei. They're randomly oriented. So some of them, the nuclei, they are arranged parallel to the epidermis. And in other places, some of these fibroblastic nuclei, they are sticking up perpendicular to the epidermis. You can see these sticking up perpendicular to the epidermis and parallel. So it's a random proliferation, which is confined to the superficial and the middermis. So that's your papillomucinosis. It's the same lesion that you would see in scleromyxedema. But scleromyxedema is a systemic condition, right? So patients also have internal organ involvement along with renal involvement. Renal involvement actually in scleromyxedema is much less as compared to scleroderma. So that's rare. But you definitely get cutaneous lesions along with thickening of the skin. But the histology of one of the lesions of scleromyxedema is similar to papillomucinosis. So this is papillomucinosis. Again, it's not a very easy slide to make a diagnosis on, but you can get this on your boards. Another thing that they talk about is that the papillomucinosis scleromyxedema, which is associated with the paraproteinemia, you often get plasma cells in the infiltrate. So, the plasma cells, presence of plasma cells in the biopsy often indicates that there may be an underlying paraproteinemia. So any questions on this particular entity?
So would you say like the main way you're differentiating this from GA is just like the increased nuclei in the fibroblasts?
Yes.
Okay.
And the discrete areas of necrobiosis are absent. So in GA, the areas that have mucin have altered collagen because it's necrobiotic, so it's broken down. So you will see some kind of an alteration in the collagen architecture. It's not really just thick, but it's broken down. It's necrobiotic. Whereas
Okay.
here it's just thick. It's not broken down, and it's a very random infiltrate along with the fibroblastic proliferation.
Got it. Thank you.
You're welcome. Okay. Because we have talked about scleromyxedema, we have to talk about nephrogenic systemic fibrosis or nephrogenic fibrosing dermopathy. This obviously is a very rare entity, and it's a challenging diagnosis. Most of these cases, they occur due to the gadolinium exposure in patients with chronic kidney disease, but certainly it can occur, has been described in patients without the gadolinium exposure. The similarity with scleromyxedema is obviously also in the clinical. They present with diffuse skin thickening. Typically, patients with nephrogenic systemic fibrosis, they do not involve the head and neck. And obviously, they also have, internal fibrosis, so it's a progressive disease. It's a serious disease to make a diagnosis of. Now, the upper portion of nephrogenic systemic fibrosis, scleromyxedema, can look really similar. But nephrogenic systemic fibrosis is a much more deep-seated process. So unlike scleromyxedema, which is just in the upper and the middermis, nephrogenic systemic fibrosis will go around into the subcutaneous fat presenting with septal fibrosis and thickening. So remember when we were talking about septal paniculitis, one of the causes of a septal paniculitis other than E. nodosum is nephrogenic systemic fibrosis. That's because it trails down the septa. So you can see in this particular biopsy, the lesional tissue is not only in the upper and the middermis, but you can see that the fibrosis, it tracks down the septum. So it presents with septal fibrosis and thickening. And unlike scleromyxedema, which is more mucinous, nephrogenic systemic fibrosis is more fibrotic. So it doesn't have much. The mucin may also be absent, but it's much more fibrotic. And all these fibroblasts, they tend to be CD34 positive. So CD34 staining is seen in nephrogenic systemic fibrosis and not in scleromyxedema. One of the classic lesion of nephrogenic systemic fibrosis is a lollipop body. So the lollipop body is, which we don't see in this slide, but in my handouts, Now, have I shared that with you guys? You guys have it from last year, right? Or do I need to share it again with you?
Could you reshare it just because we have the new first years too? And
Yeah, I absolutely will share it. But let me try to take out a picture of it. Um, let's see. See, it's probably somewhere in here. Okay. Yeah. So this is the classification which I was talking about. You know, when you talk about papillomucinosis like a myxomatosis, you have the generalized, localized, and the atypical variant. So the generalized is seromyxedema, which is actually with the paraproteinemia. The localized is any of these diseases. So again, this will be in my handout and you can go through it. And then the atypical is the one where the patients do not have the features of scleromyxedema, but they have a paraproteinemia. So you need to follow them up. But the histology of all these lesions is similar. Okay. So this is nephrogenic systemic fibrosis. You can see that the top lesion, but the fibrosis tracks around the septum. The classic thing which you need to diagnose nephrogenic systemic fibrosis is a lollipop body. These are nothing but these kind of whorl structures which have destroyed elastin fibers with deposition of gadolinium on them. So they look like these concentric whorl structures, and you need that to make the diagnosis of nephrogenic systemic fibrosis. Okay. Now, so the entity in the mucin diseases is scleroderma. So more than anything, all these terminologies are confusing, right? Seromyxedema, scleroderma, scleroderma. So we need to know the differences between them. So in scleroderma is essentially an invisible dermatosis. So you will get a thick dermis and with minimal inflammation. Now, it resembles your morphea or xeroderma, but unlike in morphea and xeroderma, where the space between the collagen bundles is obliterated, it is dermosclerosis. In this case, you do get the dermal thickening, but the collagen bundles are swollen and separated. So you can see that the collagen bundles are swollen and separated, and actually the space between them is retained. Whereas in morphea and xeroderma, you get a sclerotic dermis with inflammation. And it's the space between these collagen bundles which has that invisible mucin, which you really cannot see unless and until you do special stains. So colloidal iron is the stain that you would do for mucin to look for mucin. So scleroderma is a thick dermis, which is an invisible dermatosis. You do not see much inflammation happening. It really looks invisible, but the dermis looks thick. But remember that the collagen bundles are swollen and separated, and the space between them is retained. It just has mucin, which is kind of like invisible. So that's scleroderma. You get it?
yeah,
Okay. Then the other entities which you get mucin in is, and we're going to talk about this, is follicular mucinosis. So follicular mucinosis, when you are getting in your boards, you are getting it as a variant of mycosis fungoides. So follicular mucinosis for you guys in your boards is synonymous with follicular tropic MF or a variant of mycosis fungoides, where in true cases, that may not be the case. So it may be associated, it may not be associated. But for both purposes, when you see mucin deposition in the hair follicles, so you can see here nice hair follicles, and they have all this mucinous degeneration of the follicular epithelium with them. That's follicular mucinosis. And always remember that in follicular mucinosis, you may get a lot of eosinophils. So the background may have a lot of eos. That is completely fine for follicular mucinosis. In fact, presence of EOs is fine for any T-cell lymphoma. So you do not want to pick up something like an arthropod with mucin deposition because you're seeing the EOs. If you see mucin in hair follicles, that's follicular mucinosis for you guys. You get it? So you can see all these nice hair follicles with mucinous degeneration of the follicular epithelium. Okay. And then you also get mucin deposition as a reactive entity. We have already talked about connective tissue diseases like lupus, dermatomyositis, Godwin's papule. You will see, mucin deposition in those entities as well. So in summary, for your blue deposition diseases, we have talked about entities like pretibial myxedema, reticuloerythematous mucinosis, and your neoplastic / benign entities, which are your myxoma, follicular cutaneous, focal cutaneous mucinosis, digital mucosis, mucocele, and then papillomucinosis, scleromyxedema, lichen myxomatosis, nephrogenic systemic fibrosis, and scleroderma, and follicular mucinosis. So those are all the entities in which, you can be asked with questions regarding your mucin deposition. Okay, any questions till now?
I think we're good. Thank you.
Okay, so now we're going to move on into the pink deposition diseases. So pink essentially means, more often you're referring to amyloid, an amyloid-like substance. Let's start with your amyloid. So macular amyloidosis. Macular amyloidosis, again, is an invisible dermatosis. Not much is happening. Um, you will go from top to the bottom, and when you go down into your papillary dermis, you will see that there are these amorphous acellular deposits, these pink deposits, which are filling and expanding the papillary dermis. Macular amyloidosis most often presents as hyperpigmented patches on the back of middle-aged elderly females, and you get some degree of pigment dropout, but it's very post-inflammatory. You do not get much inflammation. The overlying epidermis can show features of like LSC. So you may have a slightly thick stratum corneum, and because really chronic friction and rubbing is probably the cause of this macular amyloid. Now, this macular amyloid is not the true amyloid protein. It actually is kevatin filament. So it's the leakage of the kevatin proteins which is producing this macular amyloid. So if very often it will stain with kevatin markers. The stain for macular and lichen amyloid is crystal violet. So we like to use crystal violet over Congo red. Congo red is something that we like to use more for your systemic and nodular amyloidosis. For macular and lichen, we like to use crystal violet, or even you can do a keratin stain. So that's macular amyloid. Lichen amyloidosis, which most common presents with lichenified papules on the lower extremity, which clinically can mimic lichen planus. It presents with more obvious changes. So the overlying epidermis often shows epidermal hyperplasia with acanthosin hyperkeratosis, as you can see. You can see patchy lichenoid inflammation, but again, your papillary dermis is going to be filled and expanded by this amorphous pink material. So you can see this kind of material which is expanding it. So this is obviously more obvious than macular amyloid because you have a clearly thick epidermis which shows features of LSC along with inflammation. And again, this stains more prominently with crystal violet as compared to Congo red. So that's your lichen amyloid. Okay, nodular amyloidosis. Nodular amyloidosis presents with a complete effacement of the dermal architecture. So here the dermis obviously doesn't look normal. There is the collagen architecture, the elastin architecture is lost. And what you're getting is this deposition of this pink eosinophilic substance in the dermis. There is often accompanying interstitial hemorrhage. And now that happens because this amyloid likes to really deposit around vessels. So it produces leaky vessels with all this interstitial hemorrhage. So sometimes this hemorrhage can be a clue. The second thing is that it's not immunogenic, so it doesn't incite much inflammatory response. So you wouldn't see any granulomatous inflammation or anything with it. So you can see this nice amorphous eosinophilic material, which is deposited around the hair follicles, around the vessels. It's around the vessels where it more commonly begins. So if it is not that obvious, if you're not seeing it as like a sheet-like pattern, then you look for the vessels and you look for deposition of this substance around the vessels. Another thing which I want to say is that nodular amyloidosis, it may or it may not be associated with underlying systemic paraproteinemia, so multiple myeloma or Waldenstrom's disease, but you have to work up these patients. Unlike macular and lichen amyloid, which are localized diseases, this may have a systemic association, so you have to work up these patients. Sometimes you may get lucky, and along with the nodular amyloid, you may have a kappa or a lambda restricted plasma cell infiltrate. So you may see plasma cells in the biopsy along with the amyloid, and if you stain it up, they may show a restricted pattern. So that makes your diagnosis really easy. But it is prudent enough to work up these patients with an SPEP and a UPEP to make sure that they do not have an underlying gammopathy. So this is your nodular amyloid. And systemic amyloidosis would also remain the same. So the amyloid deposition, which occurs in a patient with multiple myeloma or with the systemic paraproteinemia, or just idiopathic nodular amyloid, you cannot really distinguish it based on the biopsy alone. They will show similar features. Okay. In contrast to amyloid, which is a pink substance, you have gout. So gout is also a pink substance. It's your The gout is your sodium monourate crystals, and these are feathery. So amyloid is acellular, pink, structureless, whereas these are these feathery crystals, which will incite an inflammatory response. So surrounding the gouty crystals, you often see granulomatous inflammation, and they do not have any specific affinity for vessels. So it's just going to be a deposit which is lying in the dermis, which has this kind of a crystalline, feathery look to it, as you can see over here. And you see the nice giant cell reaction associated with it. So that's gout. Okay, colloid milium. Colloid milium is another, entity wherein you get these kind of fractured halonized deposits occurring in the superficial dermis. So here, again, colloid milium is one entity. If you've seen it once, you will always remember it. You can have the juvenile and the adult colloid milium. The most common which we see is the adult colloid milium, which occurs on the back of your hands with the background solar elastosis. So you often see solar elastosis, and then you can see these nice fractured halonized deposits, which have the nice two-tone kind of a tinge to it. They look both blue as well as pink. So that's your colloid milium. Again, it's minimal. It doesn't incite much inflammatory response. Okay. Now there are some other diseases which can have deposition of pink substance. So I'm going to go back into my PowerPoint and try to take that out and tell you guys. Okay, I didn't talk about this, but mucopolysaccharidosis, you need to remember these. So mucin deposition, you can also see in mucopolysaccharidosis. The biopsy will just like mucin in the dermis, but one of the questions they can ask you is the presence of metachromatic granules. This is something we do not really routinely see on our histology slide, but they can ask you about it, that you can see metachromatic granules in mucopolysaccharidosis, your Hurler's and Hunter syndrome. And, Hurler's and Hunter syndrome will also have mucin deposition with the presence of metachromatic granules in the cytoplasm of fibroblasts and in sweat ducts. So this is a question they can ask you. So we were talking about the pink deposition diseases. I'm going to come back to this, but this entity I want you to know, which is lipoid proteinosis. So lipoid proteinosis, it's a rare autosomal recessive condition. They like to ask you a lot of questions on it, with the classic clinical appearance of they mimic verruciform. They mimic your tendinous tuberous xanthomas with this cobblestone appearance, the string of bead appearance. They have, laryngeal hoarseness, along with, deposits of this material, even in the brain, producing, epilepsy and mental retardation. The histology is important. Obviously, because of the rarity of this disease, I've never seen an entity of lipoid proteinosis. But essentially, what it looks is like amyloid. But unlike amyloid, it produces this nice concentric halonized deposition, which is perpendicular to the epidermis. So you see this prominent deposition around the vessels and also around the sweat glands. And this happens to be perpendicular to the epidermis. And the difference from amyloid is that amyloid stains with Congo red, but it does not contain lipid. This will stain with Congo red, but it also contains lipid. So it's more of like, a board relevant question that they can ask you. But this kind of a concentric pink deposition around the vessels with oriented perpendicular to the epidermis is very classic for lipoid proteinosis. So they can ask you questions regarding that. We have already talked about porphyria and pseudoporphyria. So when I showed you porphyria and pseudoporphyria, I did mention that you do see subepidermal blisters, pauci-inflammatory, but the vessels, which are your donut vessels, show this perivascular halonization. So in porphyria and pseudoporphyria, you get perivascular halonization in the base of a cell-poor subepidermal blister. Erythropoietic porphyria is another entity which can present with amyloid-like material deposition, but that's again more on the around the vessels. So you can see this nice material around the vessels oriented perpendicular to the epidermis. Another thing about erythropoietic porphyria is spelling over here is wrong. That it's an out of proportion biopsy because they have massive solar elastosis, which is out of proportion to their skin. So you may see a young individual or a child who has marked solar elastosis with deposition of this material around the vessels and around the sweat glands. So these are all the other entities where you can get deposition of this pink material. Now, I wanted to show you the slide for cutaneous collagenous vasculopathy. Believe it or not, we do see this entity, and it's an entity which a lot of clinicians actually don't know about. And the clinical can be very perplexing. So the clinical is something like, your hereditary hemorrhagic telangiectasia. So this presents a patient, it's a very bizarre clinical presentation, which, often you don't really know about what you're dealing with. So often the clinical will come in as livedo reticularis, purpura, vasculitis. You can Google this entity, and the histology is classic. And what the histology shows is all these telangiectatic vessels. So you can see all this vascular telangiectasia, and around the vessels, you can see this deposition of pink material. So you can see perivascular hyalinization. So this entity is called cutaneous collagenous vasculopathy. They really don't know why this happens. Many of these patients have underlying like hypertension or dyslipidemia. So it's more kind of like a vascular response occurring to an underlying condition, which most often is some kind of a cardiovascular disease in these patients. But the clinical is very, very interesting, and the histology is completely out of proportion. So, the clinical will be very impressive, but the histology will just show this subtle telangiectasia with sparse inflammation and this deposition of pink material around the vessel. So that's cutaneous collagenous vasculopathy. Okay, so in summary, those are the conditions which will show you your pink deposition diseases, which is, these are the list of diseases we have gone through. Waldenstrom's macroglobulinemia can have varying presentations in the skin, right? So in Waldenstrom's disease, you may get amyloid deposition, but this is a very rare presentation where you again see these pink hyalinized deposits which contain IgM occurring only in the superficial dermis. It would be a very, very rare diagnosis to make, but I added that, as a part of, your completion's sake. So those are your pink deposition diseases. Do you guys have any questions?
Not yet.
Okay, so let's go to your study set. So we will try to, tackle that. Now, this particular study set, it was like a mix. So, there will be the conditions which I have not really taught you right now, but, it's okay. We're almost like kind of approaching the end of your inflammatory entity. So it's good to revise and also, talk about entities which we have not studied. So the first one is a classic example of that, the 1B. So I'm jumping straight to 1B because the 1B is the more obvious one, and that's what is going to be on your board. So what's the answer for the 1B? You have epidermal atrophy, hyperkeratosis, you have this lichenoid inflammation which has been pushed down.
Sclerosis.
Yep. And what does this look like? This is your homogenized papillary dermis. So you can see this kind of very loose papillary dermis. It's got a pink appearance and it's kind of like broken down. So, it can often become even bullous. So it has this kind of a pale appearance. It's called a homogenized dermis. The clue to lichen sclerosis is obviously the epidermal atrophy, the hyperkeratosis, and this band of infiltrate which is pushed down by this homogenized dermis. The closest differential from this is going to be radiation dermatitis. And in radiation dermatitis, you will get a similar looking dermis, but the vessels will be abnormal. So in over here, the vessels are not abnormal. So this will be LSNA. The slide 1A was the earlier stage of lichen sclerosis. So sometimes the earlier stage of lichen sclerosis can present, not, it always begins like this, not sometimes. You will see this patchy kind of a lichenoid inflammation, which can present with like a non-specific interface or a lichenoid dermatitis. So in this particular early stage, it may be difficult to diagnose the disease, but when it's well formed, it's pretty classic. So it's not the 1A that they're going to test you on, but it's the 1B, which is going to be tested on. Okay, the slide number 2. So what's happening in here? Not much on low power, right?
Yes.
Yeah, it looks.
Is that like pigment incontinence?
Yep, there is subtle pigment incontinence, but yeah, clearly it's not much. You will have to go on high power to look for what is happening. And what is all this?
There's a little
Like
bit of amyloid.
Amyloid.
Yep, yeah, so that's macroamyloid. And the pigment incontinence is always a clue. We always see that in macular amyloid. And that's because, as I said, I really believe that friction and rubbing and the damage of the keratinocytes with the leakage of melanin pigment is essential for this disease. So you can see the macular amyloid with the pigment dropout. Good. Okay, the slide number 3 is more of your connective tissue disease in the connective tissue disease realm. So it has 2 parts to it. And we have talked about again this before, 3A and the 3B. So again, by just looking at the biopsy on low power, what is the first thing that comes to your mind?
Superficial and deep perivascular inflammation,
Yep. And what does that make you think about?
like tumor lupus.
Yep, or lupus, right? So very lupus-like infiltrate. And then you have the fat underlying within it. And what's happening to the fat in here?
Sure. Oh, you're getting like lupus paniculatus.
Exactly. You can see the nice hyalinized fat necrosis with this nice lymphocytes within the fat. And you can see the really pink necrotic fat in the background. So this is your lupus profundus or lupus paniculatus. And you will always see the nice superficial deep perivascular lymphocytic infiltrate, which is also within the fat. You get it? Good. Okay, and we have your slide number 4. So what's happening in here?
There's lots of mucin.
Solitary lesion.
Solitary lesion, it's a hemorrhage. So like a myxoma.
Yep, or focal cutaneous mucinosis. Yes, the hemorrhage is from the biopsy, but you can see lots of mucin in the slide. It's forming a solitary lesion, so that will be focal cutaneous mucinosis or myxoma. Good. And you have your slide number 5. Okay. So again, on low power, what does this make you think about?
So there's like a perifollicular lymphocytic inflammation. It looks like there's like a lot of inflammation, so it makes you think about like lupus.
Lupus again, exactly. It makes you think. And this biopsy is obviously from the scalp, right? You can see the long hair follicles, and you see lots of perivascular and perifollicular inflammation. And then, so this on the scalp is very consistent with DLE, right? And then when you see, you confirm it in the overlying epidermis. And what is the overlying epidermis show? Now here, there is an artifactual blister. That's because of the liquefactive degeneration, because of there is massive destruction of the basal layer. And when you see in here, what do you see? You can see the nice interface change. You can see the alteration, the thickening of the basement membrane. You see the plugged follicles. So this is lack of DLE. You can actually also see some mucin in the slide in here. Okay. So that's your lack of DLE with secondary mucin and with the nice, all the chronic interface change. Good?
Yep.
Okay. The next one is your slide number 6. Okay. Sorry. So this one, I'm going to be talking about this in the next class. So when I will teach you about, the different kinds of, how to recognize your melanin and hemosiderin and exogenous depositions and stuff. But this again is a pretty common entity which we encounter and definitely testable for your boards. So the interesting part about this slide is that you often ignore this. So you often consider this to be an artifact. Well, it's not an artifact. You can see this kind of a big kind of a space and hole within the tissue. And that actually is what is being clinically sought after. So clinically, it may often comes in as a pigmented lesion, and it's not. It's actually a foreign body reaction to a metallic substance which has basically iron within it. So the important thing is to recognize this crystalline material which has this golden brown look, which is indicative of iron. So you see that, over there,
Yeah.
this substance in right there. And believe it or not, it's not uncommon. We do see this. So this kind of a material you need to recognize. It has a crystalline golden brown look to it, which is a metallic substance containing iron. So it is a foreign body reaction because of that. And that's why it's produced this kind of an empty space in the tissue. That's because it was embedded and it could not produce an even section during the, when the histotechs were trying to cut it out. So this is your foreign body reaction from crystalline iron. Get it? Okay. You have your slide number 7. This is a nice contrast to the things that we talked about today. So I have a bunch of slides of this in the in your study set. So it's important. So like, for example, if you get this slide and you have the differential of GA, sclerodema, scleromyxedema, and morpheosteroderma. So what's the answer in this?
I guess I would think more morphia.
Yes.
It looks like the collagen bundles are pretty like sclerotic and tight together. And it's a little bit squared off.
Exactly, it is. So again, see that morphia most commonly involves the upper and the mid dermis. So this is a lesion right there. This is normal. You see that?
Okay. Yeah.
And this is abnormal. You see the difference in the quality?
Uh-huh.
And here you can see, so unlike your sclerodema, which first of all is invisible, here you have inflammation. So it's not that. You are seeing the space between the collagen bundles is obliterated, so it's sclerotic. And morphia in some areas, like if you just pay attention to this, can look like interstitial GA because it produces interstitial inflammation, which is very common at the advancing edge of the lesion. But the inflammation is, first of all, associated with sclerotic collagen, which you do not see in morphia. And why is this not scleromyxedema? Because you're not getting the fibroblastic proliferation. So in scleromyxedema or papillomucinosis, first of all, you get mucin and you get sclerosis, but there is also fibroblastic proliferation. You do not see in morphia, even though the dermis is thick, you do not see fibroblastic proliferation. So it's not a process which produces increase in the number of fibroblasts, but it does produce inflammation. And inflammation, which could be interstitial or perivascular, or at the advancing lower edge of the biopsy, can have plasma cells, and it can also have eosinophils. So that's something that you don't normally connect with morphia, but remember that morphia can have EOs within it. So this is morphia. Okay. And the epidermis shows no change. So that's again important.
Is that in every case of morphia that the epidermis should be? Because I thought sometimes it can look atrophic, or is that not?
So the only time morphia has an involved epidermis is when there is overlying LSNA.
Okay.
But otherwise, epidermis should not be involved in morphia.
Okay.
Okay. If actually you get a thick dermis with an involvement of the epidermis, which kind of looks like interface, that's what you would see in chronic sclerodermoid GVHD. But in otherwise, you shouldn't get any epidermal involvement in morphia. Okay. You have your slide number 8. So again, this is all we are going to talk about this in the next class. So it's nice to get like a little introduction to it. So this is pretty simple. So what is the deposition here?
Calcium.
Calcium. Yep. So what does that make this entity?
Calciphylaxis.
In calciphylaxis, where do you get the calcium deposition? In vessels, right? And in calciphylaxis, you see, first of all, in calciphylaxis, the calcium deposition is not that obvious. You have to look for it in the vessels. And what is the most important thing for calciphylaxis? What do you have to see?
Like signs of death of the dermis.
Exactly. Signs of death of either the epidermis or the dermis, right? Here, the epidermis looks completely normal. And again, in calciphylaxis, the calcium is not that obvious, right? You have to look for it in the vessels. This is really obvious. This is calcinosis cutis. So the different kinds of calcinosis cutis they can ask you is just idiopathic calcinosis cutis or calcinosis cutis, which is occurring in a specific site, which is your scrotum, which will make it scrotal calcinosis. And how do you recognize something to be the scrotum? Because what is all this you see?
Muscle.
Smooth muscles. You said darter smooth muscle of the scrotum. So calcium deposition on the scrotum, scrotal calcinosis. Okay. You can have idiopathic calcinosis cutis, scrotal calcinosis, and then there is another type of calcium deposition that they like to test you on, which is subepidermal calcified nodule. We do have a slide of that in here. I'm pretty sure we do. We'll come to it, but and we'll talk about this in the next class. So that's your scrotal calcinosis. Okay, slide number 9. Now you guys will tell me what the answer in this is. Again, what does it make you think about? So your differential for this would be in your boards, they would say, you guys tell me, what do you think about this?
We love multiple choice.
You want multiple choice?
Uh-huh.
Okay, let me give you multiple choice then. Pityriasis pleva, polymorphous light eruption, tumid lupus, EAC, discoid lupus.
Well, I'm glad I didn't answer. I was going to say lichen striatus.
Okay. So lichen striatus, okay, so superficial deep, it's in the category of that, so you're not totally far off. Why is this not lichen striatus? Because look in the epi. What should you see in the epi? The epidermis in this is really, really normal. It's actually unaffected.
Okay.
And why am I saying it's unaffected? You have seen the nice feet, the reedy ridges, right?
Yeah. Yeah, I see that. From far away, I just kind of thought that band at the top looked a little like
So yes, but otherwise it's completely unaffected, right? So it's not lichen striatus. And it's not lichen striatus for another reason, which I will talk about later. It's not lichen striatus. Okay, so now the lichen striatus is out. Why is this not pleva?
It's not dirty enough.
It's not dirty enough, and exactly for the same reason, the epidermis is unaffected. And for the same reason, why is this not discoid lupus?
The epidermis is
unaffected. Now, when you look at this pattern, this is the pattern of which is described as the tight lymphocytic cupping.
Okay.
You see that? Do you recognize that?
Yeah, I do. And that's kind of what made me think of like a lichen striatus. Just, I don't know if that's like an eccrine gland, but yeah,
yes.
I see.
Yes. So this is, I completely see that, but you see the inflammation around the follicles is very prominent.
Yeah.
Lichen striatus will typically not do that. So this is either tumid lupus or EAC. And now, or one of the categories of gyvated erythema. So how do you make the distinction between the two?
Well, for tumid lupus, you want to see some mucin, but that can be hard to see, right?
Mm-hmm. And what is this?
Mucin.
Mucin. So you are seeing mucin. So this is tumid lupus, but again, it's not your in-the-face mucin. It's the lymphocytic infiltrate which grabs your attention.
Okay, so Dr. Anand,
if
you have tight cuffing, it can be, what's our differential? It can be lichen striatus if it has all the other right things.
All the things that you talked about are in the differential. But typically, I can tell you that this kind of a, so this is either superficial deep perivascular or else. So you will think about arthropod assault, you will think about light-related stuff. So PMLEs can do that. You will think about lupus, lichen striatus, all the things that we talked about are in the differential. Okay. Now, for a bug bite EOs, you will see for all the other entities like lichen striatus, pleva, polymorphous light eruption we talked about, the epidermis has to be affected.
Okay.
And for tumid lupus and EAC, there should be no epidermal involvement.
Got it.
And between the two, the tumid lupus has mucin and EAC does not have mucin. But I have to tell you, this pattern, like just by looking at it in low power. So what was the similarity between all these slides? This slide, that is your slide number 9. Then this slide, which was your slide of lupus profundus. You see the inflammation, how tight it is?
Yeah, it's very tight.
And then this slide, which was your DLE slide, which was your slide number 5. You see all that?
Also tight.
Also very tight and very dense. So that is why on low power, whenever we see this infiltrate, the first thing, this tight infiltrate, especially on the hair follicles and vessels, superficial dip, you think about lupus. So you're going into the slide thinking about your lupus. And then I start from the second thing I do is I look for eos, because if I'm seeing eosinophils and lupus is out of the picture, right?
Right.
And then I look for the epidermal changes to tie that together.
Okay. That was so helpful. Sorry to interrupt. Carry on.
Yeah. Okay. Now we have your slide number 10. So this we talked about. You have a 10A and a 10B. So this is obvious. So what is the site here?
Mucosa.
Mucosa, salivary gland tissue, and what is all this?
Mucin.
Mucin with the inflammatory response around it. So this is a,
Mucocele.
and then you, good. And then this is the 10B. Same thing. You have the mucosa, you have the salivary gland tissue with inflammation, but you don't have the mucin. But you have a space instead. And the space is that inflammatory space, and the mucin is inside the histiocyte. So even though you don't see mucin, the mucin is actually inside the histiocyte. So that's again a mucosine. Okay?
Okay.
These are subtle things, but they will get you. Because then you will be arguing with yourself, I don't see mucin, then why is it a mucosine? Okay, now this is your slide number 11, and what is happening in here?
So this looks like a lot of like pink amorphous material that makes me think more like nodular amyloid.
It is. And notice that it produces artifactual clefts in the dermis. So that's normal for any deposition disease, right? And then it has this amorphous pink substance. So the loss of the normal collagen architecture. So this is normal. Right here is normal. This is abnormal. Right? And
Yes.
then it likes to hide around the vessel. So if you are ever in doubt, like find a vessel and look for deposition around it. And if you're seeing deposition around it, that's amyloid. You see that?
Yeah.
And there will be some interstitial hemorrhage, but not much inflammation. It's a nice demodex mites in the follicles right there. It's probably it is from the face. This is nodular amyloid. Okay.
Yes.
So this is the patient you will work up for a paraproteinemia. Make sure there is no underlying systemic disease. Okay, and you have your slide number 12. So this again, we will talk about the next time. But this looks like mucin, right?
Where?
But it's too dense as compared to mucin. So this is artificial mucin. And what will do that?
HA filler.
Exactly. So this is hyaluronic acid filler or your Restylane. Good. So we'll talk about fillers next time. So this is the slide number 13. What is this?
This gout.
Gout. Yep. And you can see the inflammatory response around, like that's feathery material. Good. You have the slide number 14. This again is all for next time, but they are easy slides because once you know that you have seen it, you'll remember. So there's a scar, and then what do you see this in here?
Is that suture or?
Yep, it's suture. So we'll see different kinds of suture next time, but this is suture granuloma. Good. And you have your slide number 15. This again is for next time, but you see depositions, right? So depositions can be of black and brown substance. Brown indicates something iron, and jet black, this is what?
Tattoo pigment.
Carbon tattoo, exactly. And this can be very non-immunogenic, so it may not incite an inflammatory response. Okay, slide number 16. Now again, I have the same differential, GA, sclerodema, scleromyxedema, morphia, scleroderma. So what will you pick?
Morphia.
Morphia. So again, the square of biopsy, this is classic morphia, right? It's involving, it's ended up at the subcutaneous junction. And you can see this inflammation, and this will have, trust me, will have plasma cells in it. and it has trapped the sweat glands in it. So this is morphia. And again, you can see the epidermis is unaffected. And you can also see that morphia can extend around the septum, and that's why it produces your septal paniculitis. Sometimes morphia begins deep down here, and then it tracks around the septum, and that's your morphia profunda. Okay. You have your slide number 17. What's happening in here? Yeah. Yeah, go ahead.
So, wait.
I think there's too many nuclei for it to be like amyloid, and it looks kind of blue.
Oh, it's turning out to be blue over this, but it's not. It's really pink.
Oh,
Okay, so amyloid.
Yep, this is like an amyloid. So you can actually see the thick epidermis, thick conified layer, and you will see cell death with it because that's the pathophysiology. And you can see the nice deposition of this pink substance. This is all like an amyloid.
Okay.
Okay. You know, all the other diseases that are talked about, lipoid proteinosis, erythropoietic porphyria, it's very rare that they're going to show you a slide of it. So those are very rare entities, but they can ask you questions regarding it. And those have to be classic. So in lipoid proteinosis, they will show you like Hallenized. So they'll show you probably like one of the slides I showed you as a PowerPoint, and they may ask you a second order question with it. Okay. So this again, we will talk about next time, but what is this?
it looks like bone formation. Was this like osteoma cutis?
So this is osteoma cutis. So most of the times, osteoma cutis is idiopathic, but then you can also see it in McCune-Albright hereditary osteodystrophy and your fibrodysplasia, ossificans progressiva. So you need to know about those syndromes. And osteoma cutis, you will get the lamellar bone. So you will get a calcified bone, but then you get lamellar bone where you can see these empty spaces, which are your osteocytes, the lacunar cells within the osteocytes. So that's osteoma cutis. Okay. You have your slide number 19. Again, 1 minute diagnosis here. What is this?
Oh, a little
Myxoma.
or papillomatosis.
First of all, what is the location here?
Oh, yeah, it's April.
So what is this?
Yeah,
Yay.
What
One of
is
our
it?
first years, Emily just got it.
Yes. Oh, digital mucus cyst.
Okay, good. It's a digital mucus cyst. And very often you will see the mucin extravasation. That's not uncommon. So that's fine. Good. You have your slide number 20. So we'll again talk about this the next time, but what are these?
Are those bananas? Is that
Yep.
ochronosis?
Ochronosis, yes. So it could be primary or secondary. It could be alkaptonuria, or it could be because of long-term topical application of bleaching agents, whatever the cause, but this is ochronosis. The histology is similar. Okay. And you have your slide number 21. Oh, we'll talk about again this the next time, but what's the diagnosis here?
Is this like pseudoxanthoma elasticum or some sort of like
Yep.
is there some
It's
segmentation called,
PXC where you get they look like confetti elastin fibers. They're broken down, corkscrew. They can have secondary dystrophic calcification. So that's PXC. Now, if they do not have PXC in the choice, but if they have something like deep penicillamine therapy, that's also the right answer because deep penicillamine therapy produces PXC-like changes.
Really?
Mm-hmm.
I feel like penicillamine does everything. And I've never seen a person on it.
Yeah, it's a bad drug.
It really
It's a
is.
bad drug, yes.
Causes
But yeah,
everything.
but they remember that deep penicillamine therapy or PXC, the histology would be similar. Okay, how about this? So what do you?
Mucinous Versus sometimes if we weren't on the chapter, I'd almost just think solar elastosis. How are we telling that apart?
Because solar elastosis is destroyed. It is not, if you look up in over here,
Yeah.
this is like, it's kind of a fluffy material. Like it's not, the elastic fibers are actually normal. Like this is solar elastosis.
Okay. I see what you mean.
But
Fluffy
this is
like
like,
that.
yeah,
Okay.
this is true
Fluffy.
mucin.
Fluffy. It's looking like kind of normal amount of fibroblasts, I think.
Uh-huh.
So probably scleroedema.
In scleroderma, you don't see the mucin.
Oh, it's too invisible, right?
It's completely invisible. You see the thick dermis with swollen and septic collagen bundles. Here you're seeing really obvious mucin, but with nothing else. So that's pre-tebal myxedema.
Yeah. Okay. Super obvious mucin. Got it.
Super obvious mucin, but no other inflammation.
Okay. Love it.
Good. So it actually looks almost like papular mucinosis. Not papular mucinosis, sorry, your focal cutaneous mucinosis. Papular mucinosis, the mucin is not obvious. It actually looks like GA, and then you have to make, like you have to go up on high power and you look for all other things and then you see the mucin. Okay, this is the next one, 23. This is the one that I was talking about. So you have your idiopathic calcinosis cutis, throatal calcinosis, and this is the third type. This is subepithelial calcified nodule. It most common presents as a chalky lesion on the face of a child, and what you basically get is the pseudoepitheliomatous hyperplasia, and juxtaposed beneath it, you get this calcium deposition.
Okay.
So that's subepidermal or subepithelial calcified nodule. Normally, you get calcium deposition with like a normal epidermis, right? You get it in the dermis or you get it in the fat. In this condition, you get it right beneath the epidermis, and the overlying epidermis is hyperplastic.
Are these like from acne scarring from a cyst that ruptures, or what's the cause of?
I don't know the cause of subepidermal calcified nodule because very often you see them in like really young kids. So, and it's on the, I would like to know, look it up. I don't know what the cause of that is.
Okay. Okay.
But it's a classic presentation on the cheek of a child. It looks like a chalky lesion. Very often it comes in as a cyst or a wart.
Ooh. You see a lot of them?
We definitely do see. I have seen at least, it's not a lot of them. Now, since the past 11 years I've been practicing, maybe I've seen at least 4 to 5 cases of it.
Yeah, enough. Interesting.
Yeah. Okay, so this one is a little tricky.
We have updates for you.
What is that?
The most favored hypothesis is that it's calcium deposition in a pre-existing lesion. But I don't have the full text. But so I don't know. But it said it's a form of idiopathic, but what does it occur in?
I don't agree with that. But what they are trying to say here, for example, like in palomatricoma, you can see sometimes you can just leave behind the calcification and you do not see the shadow cells. But honestly, subepithelial calcified nodule always looks like that. Like instantly when you see it, you know it. And you can predict the clinical. So it is something very specific, but I don't know.
Yeah,
okay, this
so
next
it's
one looks
weird,
crazy.
yeah.
Let's talk about it.
Yeah. Okay, so this is a slide number 24. So now in this slide, this is a little confusing because a lot of people think like this is lots of mucin, but this is not mucin actually. This is also like really badly elastotic skin.
Wow.
But the action is in here. So what is this? If you can recognize a reaction pattern, you know the disease.
I see a lot of dilated vessels.
Yes, but does the epi look normal?
No, it looks like there's some squamatization of the basal layer.
Yep, yeah. And there is atrophy and there is this
It's gotta be
interface change.
pleva.
Okay, so you said squamatization and then you are saying pleva. What does squamatization mean?
Chronic lichenoid.
Chronic.
Yeah.
So is pleva chronic?
No.
Nope, it's acute. So this
It's got to be either DM or
yep, or lupus. It's a connective tissue disease or mixed connective tissue disease. You can see the nice thickening of the basement membrane, the atrophy, the chronic vascular alteration, the necrotics. You talked about the squamatization. So all of these are features of chronic interface chain. And you can see that, and in chronic interface, you can get this kind of like a halonized look, which is actually not halonization. It honestly is the destroyed basement membrane.
Okay.
You can see that.
Yeah.
So that's your,
Fun.
yep, that's lupus.
Wow. That is
Okay.
impressive solar elastosis.
It is, yes. So I don't have the slide number 25 here because I'm going to teach you guys next time. That's the filler, which is your polymethyl methacrylate. So we'll talk about that next time. The slide number 26. I'm going to possibly I want to do these after I have taught you guys the other cases, because I want to we're going to talk about recognition of different kinds of pigments. This is an example of a blue nevus, and the main point here is to determine what kind of pigment you're looking at. So this has melanin and not hemosiderin. So hemosiderin is golden brown, it is refractile, it shines back at you, whereas this one is just brown. It's not golden brown. It's not shining back. So that's melanin pigment, along with the background proliferation of the spindle stellate dendritic cells, which is your blue nevus. So very often they will try to confuse you with a dermatofibroma. So a dermatofibroma can have hemosiderin pigment, but if you see melanin pigment with background fibrosis, you will think about a blue nevus and not a dermatofibroma. So we're gonna do these slides. Let's end for today, because the rest of the slides, a lot of them I want to cover after we have done some of the diseases.
Okay. Well, this was so great. Thank you, Dr. Anand.
You're welcome. Let me show you the slide number 27 1 minute. So 27 is your scleroderma. So we were talking about the epidermal change, right? So you can see that everybody agrees that this is scleroderma, morphea scleroderma.
Very square.
Very squared, very thick dermis. You can see the loss of the space between the collagen bundles, right?
I see
But-
some little inflammation too.
Yes, you do have the inflammation, but in this particular instance, the overlying epidermis is actually affected. You see that?
Because it's thickened.
Like, yeah.
It's thickened, exactly. And it has all these holes and spaces. So guys, you can completely forget about it. But because I was telling you this, I want to tell you that chronic GVHD, which can be either lichenoid or sclerodermoid, which is indistinguishable from scleroderma, the overlying epidermis can show some interface change. So this was actually from a patient with chronic sclerodermoid GVHD. You wouldn't be asked to distinguish this on your boards. On your boards, this will be morphea/scleroderma. You can see the nice entrapment of the sweat gland. But because we were talking about it, I wanted to pinpoint that. The next time when I will teach you these these slides, I won't even like distract you by telling you that. But because you were smart enough to recognize that, I wanted to show you.
Interesting.
Okay.
Oh, yes. Thank you.
Thank you, Dr. Anand.
Sounds great.
Thank you. You guys have a good evening.
Have a good trip.